It's Doc Talk, beginning of October 2021. Fall's arriving. Things are happening in the healthcare system, much of it on the good side this week. A lot for us to cover. So let's talk about a couple timely things. A lot of questions this week about what is going on in the healthcare system and why are we having so many problems in the healthcare system. The American healthcare system usually runs in cycles, like many other things. A lot of it is weather dependent, but very seasonal. Our typical in the broadest stretch of the country, which is temperate climate and gets cold in the winter, the cycle of business in the healthcare community begins with the winter months when infectious diseases are spreading, people are indoors. And so we begin to creep up in our volumes in about October, November, December, and reach typically what is our busiest time of the year, December, January, February in the health system. And then things go back down again, and people begin to have respite periods from infectious diseases. Summertime is more trauma events and injuries and things that relate to outdoor activities. So that's the normal cycle. Well, the last 2 years, we've been a little off cycle with all of the healthcare system in America essentially shutting down, except that was related to COVID and emergency treatment. So screening for cancers and other diseases, routine cardiac care, routine orthopedic care, people getting hips and knees and other joints replaced, all of that kind of came to a halt. And we carried that through the winter, which was so very busy taking care of COVID patients last year. And then as the country began to come back into a lower period of time with COVID, the hospitals began to kick up and do all of that delayed set of procedures for people. So June and July in particular, we began to see a real up-ramping of medical care in hospitals that had been delayed. There were also a lot of staff members in the healthcare system that had decided to take a little break and a much needed break for vacations and other things, and a little respite time to regather with their families and to rebuild the health system and begin to write after action reports on COVID because we thought we were in the clear. In fact, we weren't. And very rapidly across the country, beginning at this point in this wave in the middle of the country and spreading out, we began to see COVID patients re-enter the hospital very quickly. And then we had kind of these leftover patients that were still trying to get their hips replaced and their cardiac work done and their screenings done and other things. And lo and behold, we had a very busy health system. We had very busy hospitals. We had no beds. We had no staff. That is a crisis point in this country when we don't have healthcare resources. What happens upstairs in the units is they get to the point where they're full, and then they tell the emergency department, keep stuff in the emergency department until we can open space upstairs. Boy, those poor people that work in the emergency department, like me, we were busy in ways that we had never envisioned in the first round of COVID. We had sick COVID patients in the emergency department for lengthy periods of time, along with sick heart patients, sick people who'd broken their bones, sick people who had summer-related things that were going on. We had a little run of bee sting anaphylaxis, and bee sting anaphylaxis people can't wait in line for their care. People with routine emergencies that weren't as timely oftentimes were backed into the ambulance entrance, and we couldn't offload. So a little understanding of how the entire global health system fits together and how we in Fire EMS are part of that because we're bringing in the unscheduled people, the people who have unusual emergencies and a bad day, no matter what caused it, and us being able to access the health system and get our vehicles and people back in service really important to us. And it still is compromised across the country. Many of you, like me, are finding ways along that entire initial care spectrum to make sure that we keep the system running, that we have medic units available to pick up the next MI, stroke, gunshot wound, or child who fell off the playground equipment. and to be able to provide care for timely emergencies, things like bee sting anaphylaxis that can't afford to wait for 30 seconds in some cases to get life-saving care, and then to be able to get people into a care system that works for them. What's happening with COVID this time around is we have younger people who are getting sick with it, and some of them very sick. And those people are glued into hospital beds for a longer period of time. Some of them, unfortunately, are still going to die, but they're in the hospitals for longer periods of time. Our COVID patients a year ago were much more elderly, and the more elderly, frankly, had a very quick disposition. They either did very well and were released back home, or they didn't do well and they died. This time, we have many more younger people who are longer periods of time in the hospital. So those beds are full with them. And then that backs up into the emergency department, which is what we appreciate in the EMS system as boarding time. That is wall time or ambulance patient off delays. And its ambulance is not available when we need them for transport in the field. Let's talk about another healthcare problem right now, and that is a shortage of our supplies and our medicines. For 10 years, we've been dealing with a shortage of medicines. That came around some decisions by makers of medicines that weren't able to make all of the medicines safely that were needed. So they began to cut back on certain production lines. And it resulted in us having a drug box when we opened up and looked inside that didn't have the medicines that we needed. And it resulted in a lot of education that was going on about substitutes for our usual medicines. Or it's packaged sometimes like this and sometimes like this, and sometimes it's square and sometimes it's round. Really, really difficult time trying to keep the drug box full with medicines that our paramedics and EMTs were comfortable using. And in a safe way for the patient, who said, you know, the last time you came here, you used this medicine, it was really effective. Don't you have that medicine again? Well, no, we don't. It's in shortage. We began to recover from that over the last 2 years and began to see our drug short list get smaller and smaller. Well, guess what's happened this summer? It's creeping back up again. And I shouldn't really use the word creeping. It is jumping back up again. So we now have quite a few of our favorite medicines that are in shortage. Those things include epinephrine in the cardiac arrest version. It includes nitroglycerin in the form that you put underneath people's tongues. It includes many of our cardiac medicines, our injectable cardiac medicines. It includes different forms of glucose, so that we're, again, going to have to go back into the period of time where we're looking at alternate medicines to use or alternate packaging of medicines, if any is available at all. This morning, I got my first notice that we are short on 20 gauge IV catheters. 20 gauge IV catheters. That's a favorite. That's a staple. You know, that's 101 in EMS care, is putting a saline lock in with the 20 gauge catheter. We don't have any available in the hospital system. And so we're going to use up our supply of 20 gauge catheters, but all of a sudden we're going to be using 22s or 18s until they go into shortage. And then it's going to be, well, what else do we need to do? Or are we going to be drilling to put in an intraosseous catheter? This is really crazy times. And I say this because IV catheters are on the front end of what potentially are in shortage for us in coming months and maybe years. All of supplies have become short. Chips, so that you can't buy a new truck as either a staff truck or a frontline response truck, because they're not making the trucks, they're not making the cars. You go to the grocery store and stuff is in shortage. You go to the drugstore and stuff is in shortage. So be aware the impact of the pandemic on worldwide supplies of all kinds of things has changed. I'm not familiar with an IV catheter shortage at any point in a 40-year career, and that's where we are now. Let's talk for a moment about vaccines, because this week saw the official recommendation from the federal government, and it came through both the FDA and the CDC, that we are going to be starting a booster program. Right now, that booster program has impact on one group of individuals, and that is people who got Pfizer vaccines. So that was the first available vaccine. It was in the 2 vaccine series. And the notice from the federal government said this week that those over age 65, those with immune compromise conditions, and healthcare workers and other people who work around vulnerable populations are eligible for the third vaccination of Pfizer vaccines. So for those of you who are in that bucket, it is your opportunity to go and discuss and make preparations for and getting the Pfizer vaccine if you would like it. It's the same formulation that they have used since the beginning. It's that same little quantity of medication, 0.3 cc's. It is 6 months after your initial injection, so that's why they call it a booster. As of yet, no guidance on Moderna or Johnson & Johnson vaccines. We anticipate that will come over the next couple of weeks. And very good news this week. Today, Pfizer released all of its vaccine data on children between ages 5 and 11 to the FDA. And the FDA and the CDC will begin to study that data and make a decision about release of vaccines for those down to age 5. Many of you have been waiting for this because you want your children vaccinated. From the early releases on the data, it is both safe and very effective for kids in that age group. And it will be wonderful when we get to the point where we can vaccinate all the way down through the ages and allow the kids to be able to go to school and feel much more safe, that they're not getting sick themselves, they're not bringing something home for other members of their family. And the kids oftentimes, again, are the pool where variants begin to take place, because kids are a little factory for viruses. And all of you who are parents know that, because the kids bring home the stuff from school and the next thing it's running through the entire family. So good news for the week. We have a decreasing number of patients with COVIDs, cases that are in both our community and our hospitals and going to the morgues, and that's really important. Unfortunately, the deaths are the last thing that will begin falling, but they are beginning to fall in most regions of the country now and overall in the country. We have more vaccines available for the age groups right now over age 12. We're continuing to work on a couple more vaccines that'll come available in the fall months. That's AstraZeneca and Novartis. You can expect to hear some news about them over the upcoming months. Good news about pediatrics, so that's age 5 to 12 vaccination. It likely will get approved over the next 3 to 4 weeks. That's the likely time frame that the FDA CDC will approve it. And very importantly, we're getting a little bit of the healthcare system back working again and beginning to reduce the counts of patients in the hospitals and recover our hospital systems, so that can release some of our medics back early and get us ready for the next calls that we have to take. Doc Talk, beginning of October. Really appreciate what you do. Have a safe week, and we'll talk again next week. Thank you.